School of Medicine and the chief of the Division of Derm at the Philadelphia Veterans Administration Hospital. She had completed residencies in both internal medicine and dermatology, as well as an immunodermatology fellowship before she joined as faculty at University of Pennsylvania, and has developed an internationally recognized program in autoimmune skin diseases there. She is a clinical and translational researcher focusing on cutaneous lupus, dermatomyositis, and autoimmune blistering disorders with a focus on improving the treatment and outcomes. She has numerous publications. Her work in lupus and dermatomyositis include disease severity tools, mechanisms of disease, biomarker studies, therapeutics, among others. Her work has been funded by the Dermatology Foundation, NIH, the VA, the DoD, and numerous autoimmune disease foundations and industry. She is a co-founder of the Rheumatologic Dermatology Society and past president of the group. She is co-founder of the Medical Dermatology Society and a recipient of their Lifetime Achievement Award. And in 2020, she received the Lifetime Career Educator Award from the Dermatology Foundation. She has served as a mentor and generous resource to countless individuals, from junior learners, grad students, med students, other dermatologists, and faculty, including myself. And as you can see, Dr. Werth is devoted to medical derm and to rheumatologic diseases of the skin. She's an advocate for her patients and patient care, and also for the rheum derm subspecialty within our field. Her work has brought increased recognition to the field, and you won't have a discussion about lupus or dermatomyositis without her contributions being a part of the conversation. We are very lucky to have her as our speaker today. Thank you for joining us virtually.
Thank you very much. I'm hoping you can hear me.
We can.
Yeah. It's great to be here, and I really enjoyed the cases that you had today. They were right up my alley, and anyway, it was really fun to hear that the management is not very different between the different coasts that we're on. So today I've decided to focus our talk on dermatomyositis, and there's really been a lot going on in the area of autoimmune skin disease. It's really quite an exciting time. Just in every respect, whether it be pathogenesis or just even advancing treatments. And it really is, we're reaching a very critical stage where I think we're going to have a lot of good options for our patients. Having said that, I have conflicts, most of which I'm rather proud of, because finally people are interested in dermatomyositis, and this is a relatively new thing. And I've been involved with developing a disease severity tool for dermatomyositis. So I'm going to give you a bit of an overview, but try to bring in some of the newer aspects that have been going on in the field. And first to say that this is kind of the level of the epidemiology we have. This was a Mayo Clinic Rochester epidemiology database study with 29 patients that were seen over a period of quite a number of years, so about a patient per year. And I often say I wish I had that kind of practice, because we see so many patients now with DM. But in any event, what this is telling us is that the incidence is about 2 per million based on this population of patients, and that about 21% of them were felt to have clinically amyopathic DM, realizing at the time that really it was not even recognized as a subset of DM. So it might be higher than 21%, and it's very important to advocate for these patients who are obviously having issues. Now, in terms of the skin features, what's been thought as pathognomonic would be Gottfried's papule, Gottfried's sign. We'll show you some pictures of that. And these are erythematous papules, or macules over the joints, over the elbows if it's off the hands or knees. Characteristic would be heliotrope, periungual telangiectasias, dystrophic cuticles, and photodistributed violaceous erythema. Then there are a lot of secondary changes, and this is just a list of some of them. But you can see erosions and ulcers and vasculopathy, and certainly lots of poikiloderma, which is basically dyspigmentation and telangiectasias, and superficial atrophy, as well as calcinosis, which we see, although more often in pediatric cases. And if you ever want to talk about therapy, this is really an area of need that we're really not good at. So we did a study a number of years ago to show that really the skin findings in clinically amyopathic DM are identical to those seen with classic. And classic being muscle and skin, and clinically amyopathic meaning that they're skin predominant with, if anything, very minimal changes found on just diagnostic testing for muscle. And the reason for this is because it's been very hard sell to a certain extent within the rheumatology community to convince people that really this is part of a spectrum disease, a little bit like lupus, where you've got cutaneous lupus on one end and SLE on the other. And it's really the same for our patients who have clinically amyopathic DM. And I'll go into a little bit of detail about this, but essentially the whole point here is just that the percentages that we see for these different manifestations that I just told you about, it is really identical. So just to review, one can see this malar erythema with involvement in the nasolabial fold being fairly characteristic. Also on the what we call restive phase, namely on the scalp, on the forehead, on the chin, via the neck involvement, heliotrope you can see here. These are very characteristic features. This is Gautrins with erythema over joints, and if you some patients have papules, and then you can have also a Shaw sign like you're seeing on the right here. And I wanted to digress a little bit to talk about what goes on in patients who have these erythematous lesions over joints. We know one of the hallmarks can be increased glycosaminoglycans, which you can stain for with Hale stain. And it's sort of a very mild term for this is mucin, which is really a lot of different molecules, but we've been able to characterize them a bit in DM. And essentially what you get are in mucin is this is in non-Gautrins DM lesions, but that we've studied has been primarily chondroitin 4 sulfate as a composition for the mucin. And these have immunomodulatory effects in vitro and may activate inflammatory cells. So we were interested to look at what goes on actually in Gautrins and in normal skin in terms of the presence of chondroitin 4 sulfate and also core proteins for what we'll call C4S, namely CD44V7. And it turns out that what you can appreciate is when you have DM over joints, you get a lot of staining for CD44V7. We see very similar staining for C4S and for osteopontin, which is actually also binds to C4S. And these things are all able to activate the immune system. And so if you look at normal skin, you don't see nearly that much in the way of C4S and these other molecules. And then if you look at controls, control PIPs or healthy control, it really looks quite different and not nearly as prevalent. So we were interested in thinking about whether there was in fact something, this is related to why there's such persistence and characteristic findings over joints. We also know that osteopontin is a binding ligand for CD4V7, and this interaction has been implicated in chronic inflammation and is present in various areas in the skin around where we tend to see the C4S and CD44V7. And so when you stain for osteopontin, same deal. You sort of see a lot more staining here in brown in the over the joint DM lesions as opposed to non-Gautrins. And so together, we think, and we've shown, at least in vitro, that there seems to be increased binding of inflammatory cells. So one of the ways that we did this was we took fibroblasts in culture and stretched them over beads, and we're able to show that with stretch you actually get induction of CD44V7, and this is fairly time sensitive, and over time it goes back down again. And we were able to show increased mRNA and protein that correlated with this increased amount of CD44V7. And so we think that there's increased osteopontin and binding partners in stretch areas, and we've actually, again in culture, we're able to show there were increased cells adhering to these stretched fibroblasts relative to non-stretched, and also where we had not added osteopontin. And so likely this is leading to the increased adhesion to skin and some of the difficulties we run into in terms of treating these patients. And this was an interesting extension of that, which is a clinical observation that if someone has a stroke and can't really actually flex or stretch their joints, that and this is the same patient who is paralyzed on the right, you can see that there's Gautrins here and not on the right. And so again, the suggestion that this flexing is certainly part of the pathogenesis. And I don't want to suggest that this is isolated to DM, because we know that you can see psoriasis in this distribution and other lesions as well. But it's just interesting to think about the role of stretch proteins. So going back to the clinical findings, so we've got the V of the neck, which is also quite violaceous quite often and very characteristic. You can get alopecia, and it can be extensive, and it can actually very rarely be scarring. And this is the kind of erythema off the joints, again in stretch areas that we can see, sometimes in the elbows, knees, the malleolus, and again the Schallstein going up into the neck and into the scalp. And the scalp is actually a very common early area and a huge problem. The periungual telangiectasias are very characteristic, and I use a lot of my dermatoscope in my patients to see if there are alterations, whether it be dropout or dilatation or nasal or hemorrhage, and so this can be a very helpful diagnostic finding, because a lot of patients are not as easy as the ones I'm showing you to diagnose. And this is showing the confluent erythema, photodistributed. You can get ulcers. And you can get this, but in this location, you'd want to be thinking about MDA5 antibodies and potential association with rapidly progressive ILD, which has a very high mortality. And so it is really important to think about the internal aspects of what's going on with these patients. And that brings me to mechanics hands, which here you can appreciate there's erythema and also desquamation and some erosions in areas typically on the first and second fingers, but you can extend into obviously into the palmar surface and other fingers. And we were interested in finding out whether in fact it was so specific a finding in terms of having ILD. And we characterized the incidence of Gotrins papules and mechanics hands in patients who either had low DLCO and ILD or those who didn't have lung findings. And what you can see is that there is in fact more mechanics hands in patients who have lung involvement, but you still see lots of mechanics hands in patients who don't. And so I think it's, I always think it's nice to realize that it doesn't mean that this patient is on their way to having lung issues. And then and similarly, you can see more Gotrins papules in those who do not have ILD, but clearly you can also see it in those who do. So this is just helpful to think about the clinical findings and what is the significance. And I think we sometimes overvalue the significance of mechanics hands in terms of lung findings. Now the skin biopsy is also really interesting, and I'm not going to go over it too much here except to say that you can't tell the difference between lupus and dermato, and that is a huge problem for our patients, because very often the biopsies, instead of being read out as interface dermatitis, they're read out as lupus because it's thought that lupus is more prevalent. And so very often the patient is assigned a diagnosis of lupus when in fact maybe they don't have that diagnosis. And it's helpful when they have glycosaminoglycans on the skin. I will mention we recently published a paper about epidermal spongiosis that we've also seen in about 10% or so of the patients. And so not all the patients know how to read a textbook in terms of the findings, and it's really important to realize that this is a guide but not an absolute. And so again, to emphasize, there's a differential here. And one of the reasons why, and this has been a struggle for me and for other people in the field for many, many years, is that we had diagnostic criteria that were developed by rheumatologists and neurologists, and they were called the Bowen and Peter criteria. They developed in 1975. They were published in the New England Journal. And what you can see is if you didn't have a muscle involvement, then you didn't even have possible DM. And the diagnosis was totally hinged on having a rash, but also having at least one muscle criteria. And so it didn't allow room for clinically amyopathic DM. And that has been a source of confusion for the field up until this very day. It happens almost every time that I practice and see new patients. It's really an issue. So the problems with diagnosis is that, again, between the biopsy and the clinical, they often are called SLE. They meet SLE criteria. They can have malar rash, photosensitivity, ANA positivity, oral ulcers. And there's actually a subset of lupus rheumatologists who would like to claim DM as part of the lupus spectrum. And so I think it's really important to highlight that they really are quite distinct, although clearly patients have overlaps between both. But it's clear that the organs involved in DM more often are going to be lung and muscle. And if you actually look at the SLE criteria for systemic disease, you'll find that some of them are actually likely misdiagnosing patients with DM, because myositis, for instance, is one of the actual is on the SLE criteria for systemic lupus. And so there's some inherent issues with the way patients are diagnosed. So, and again, we talked about the skin biopsy and the criteria that are a problem. So a number of years ago, we actually went back into our patients, and we now have about 400 patients in our prospective database that we've been following. And we were able to find that of the 232 at the time, that only about 44% of them coming in the door were diagnosed with DM, and the rest were called something else. And these are the patients that we saw and looked pretty characteristic in the way that I just showed you in our clinical findings. And what were they called? So 37% were called lupus. 30% were undifferentiated connective tissue disease, and I find that to be the wastebasket that many of these patients get put into because they don't have muscle. They get called undifferentiated. Then there's undiagnosed, and then you have other, which can be psoriasis, eczema, you name it. And so this was published not that long ago, but it does indicate that we still have a lot of work to do in getting these patients properly diagnosed. Not to mention that it can be perineoplastic, right? And so you'd like to be able to know that you want to look for those things. Now, I had the opportunity a number of years ago to work on the steering committee to develop new dermato criteria. And I felt a little bit lonely on the steering committee because I tried to advocate for amyopathic DM in a group of rheumatologists and neurologists. And when I brought up that we needed criteria that would identify these patients, I was basically told that I would mess up their statistics. And I couldn't figure out what they were talking about because like half my patients had amyopathic DM. So I went back to Penn and we looked at the CPT codes for Dermato over a 3-year period of time that presented to rheumatology clinic versus dermatology. And I think you can appreciate that there weren't a whole lot of amyopathics that the rheumatologists were seeing, and there were 2 reasons for this. One, maybe they don't see the skin patients as much, but secondly, they probably get called something else. And so, so they saw lots of classic DM, and I saw some, but not nearly as much. And so one of the things that I think has been a take home for me over the years is that when you're in different fields, you tend to see the disease in a different through a different lens, and it really colors how one thinks about things. And that's true for neurologists who are taking care of these patients as well. So we do now have new criteria, and they've been published, and you can see some of the references here. Ingrid Lundberg led that effort, and we ended up with 3 criteria for skin: heliotrope, Gauthrin's papule, and Gauthrin's sign. And if you have 2 out of 3 of these, then you can now be called having a dermatomyositis and not even qualify, but it actually fits into the criteria. So that's great, but it's probably not enough, and we know that there are many more criteria. And so there's actually an ongoing project now that is an international project to try to improve on these criteria. And we're working with Ingrid and the original criteria group and through EULAR ACR to try to improve on the numbers of variables and the sensitivity for capturing our patients. But the other thing I should mention is that, again, the rheumatologists are very focused on muscle biopsies, and so they have criteria based on these criteria that include muscle, if you have a muscle biopsy or don't have a muscle biopsy. But I had a very hard time getting them to understand that the patients that were selected for the criteria all had skin biopsies, and that, in fact, that's a very important component of diagnosing DM. And so, although you'll find like a 1 sentence in the final paper saying they recommend getting a skin biopsy, it's not really baked into the criteria currently. And so when we went back and looked in our prospective database, we were able to show that these new criteria work for about 73-74% of the patients in diagnosing the amyopathics, but we're still missing a bunch of patients. And these are really classification, not diagnostic criteria, and so that you could say that's fine. But in fact, many of the patients don't have those 3 manifestations, but they might have something else that's really important in terms of their dermato. And so we really do need to refine this further, because as we go forward and have more trials, we want to be able to include more of our patients in them. So I want to move on and talk a little bit about pathogenesis, and this is pretty interesting and a little bit complicated, but it's clearly a combination of UV light that's a trigger, genetics. We know that we've heard already today a lot about the type 1 interference. We're going to be hearing a lot more about them, and they're different in different diseases, which is also fascinating. The inflammatory cells in the skin, we just talked about how the H&Es look identical between dermato and lupus, but in fact, when you start drilling down on what inflammatory cells are there, they're completely different. And so that has implications for how we think about approaching therapy, and it turns out that the interferons are somewhat different as well. We want to talk and think about medications and herbal supplements. I'll talk a little bit more about that, and then the role of autoantibodies here. So in terms of the interface dermatitis, we know that there's, again, inappropriate activation of the type 1 interferon system. There's interferon-regulated chemokines that aid in recruitment of CXCR3 positive cytotoxic lymphocytes to the dermal epidermal junction. And we know that there's a lot of cells that end up migrating there between dendritic cells, macrophages. You get apoptosis of keratinocytes, release of nuclear antigens, and you stimulate an innate immune response in a toll receptor dependent and independent fashion. There's a lot of work that we're doing to try to understand some of the pathways that are involved and in triggering the immune response. So in the skin, we know that there's a interferon signature both in skin, blood, and muscle. And what's interesting is it's more of an interferon beta signature and interferon gamma levels that are correlating with the activation of the interferon-induced genes. And they're very specific genes that are differentially regulated by type 1 versus type 2 interferons, but most of the interferon response genes are upregulated by both. And so it's not always so easy to figure out which of the type 1 interferons are responsible, or even the type 3s. So here you can see a study that was published a number of years ago that's looking at the transcript level versus the interferon scores. So the interferon scores are taking a number of different genes that can be upregulated by interferons, and because they're not all upregulated in the same way, but you can get a composite score based on a set of genes, and then you can look at the transcript level and see what's the driver. And here you can see the beta is correlating pretty nicely with the interferon score. So the higher the transcript level for beta, the higher the interferon score. And the same thing is true for gamma, but it's not true for kappa, and it's not true for alpha. And so this is important to think about in terms of what the drivers are. And we think in lupus, at least a lot of the work that's been done has been more with interferon alpha, although there's clearly beta there as well. So one of the things that we were interested in, and this has just recently been coming out, is that we're seeing many more myeloid DCs in the skin of patients with dermatomyositis, and not so many PDCs. And we've been able to quantitate these, and we started doing this with just aminoperoxidase staining, and we've now gone on, and this is actually looking as part of that paper I just showed you, where we wanted to understand if there are differences in responders, for instance, to hydroxychloroquine versus non-responders. And what we find is that the non-responders, there's a trend to having, well, it's statistically significantly different, that the non-responders tend to have more of these myeloid DCs relative to the plaquenil responders. And so you can see there's not much of a difference in the interferon alpha or beta, but clearly a difference in terms of these myeloid DCs. Now, another cytokine that we've been interested in has been IL-31, and it's an interest obviously in many diseases, and especially related to pruritus, whether it be atopic dermatitis or prurigo nodularis. But what we've been able to also show in dermatomyositis is that IL-31 plays a role, and it's increased in lesional DM relative to non-lesional and to healthy skin. And same thing is true to some extent with the receptor, and that there is a linear correlation between IL-31 and the itch score in our DM patients. So IL-31 is a bit of a driver, and certainly something to think about in terms of biomarkers. Now, more recent work we've been doing has been using the tissue mass cytometry to really look at numbers of dermatospecimens, actually in the context of a trial. But we've learned a lot about the biology and what's going on at baseline before the trial. And what this is showing you, we were able to look at, and what's kind of neat about this is you can basically look at like 39 different antibodies, metal-labeled or halide labeled antibodies that stain the tissue at the same time. So you can see pathways and cells in the same sections, and you can get a real sense of which ones are associated with which, and which ones contain which of the inflammatory cytokines. And so it's really a wealth of material. But again, this is just showing, for instance, if you look up here, the macrophages are important, the CD11C MDCs are important, and we can define these cells based on different antibodies. For instance, BDCA2 is identifying PDCs, but we really don't find many PDCs in this population. And up here you can see PDCs here, but there's just about nothing. The red would be a lot of PDCs, and we're just not seeing, it's white, it's not really there as much. And so, as you can see here, we're looking at things like interferon beta, IL-31. We can see which cells are making it. And so this is a very powerful way of beginning to think about the heterogeneity, but also what moves in the context of a clinical trial, and also to be able to compare to healthy controls. So we wanted to look, there have been a few reports, and we heard about TNF inhibition and sort of the paradoxical psoriasis. Well, the same thing you could be said in DM. We know that TNF inhibition increases interferon signature, and we heard a little bit about why that is potentially. And so what can happen is people really flare their DM, and some of the patients who initially present with DM have an inflammatory arthritis, and that might be their first presentation. And so they may be labeled as a seronegative rheumatoid arthritis type patient, be given a TNF blocker, and lo and behold, they develop a rash and fever and lung problems, and really evolve rather quickly sometimes to dermatomyositis. So when you see a new onset DM, you want to maybe make sure if they're on a TNF inhibitor that they get stopped. And then the idea again is that there's a cytokine shift hypothesis that basically when you block TNF, you're promoting interferons and altering the balance of the cytokines that are produced, and leading to a type 1 interferon driven process. So in terms of other etiologies for DM, I do want to highlight something that I think is important. And there was actually today a paper that's talking about, just how is autoimmunity actually increasing in the US? And I think it's really hard to get population-based data, and especially in DM, which can't get diagnosed, it's almost impossible. But when you start seeing patients who seem to have taken a substance, and then all of a sudden, shortly thereafter they get dermato, you start to wonder. And so we started seeing a series of patients, and it's more than 3, but initially starting with 3, that had taken isolene for weight loss, and shortly after that either had acute onset or a flare of their stable DM. And so this was one of those patients, and here we can see the biopsy with character and some thickening of the basement membrane and the interface dermatitis you can see here. And some of these patients can be quite severe. This is the second patient that we saw who, again, shortly after taking isolene started having problems. So we did a lot of in vitro work, which we did publish, and showed that basically the substance induces a lot of pro-inflammatory cytokines in DM immune cells, and it seems to be going through TOL4. And because if you block TOL4, you could block the whole induction with isolene. And I think it's really important to take a very careful history of what patients are actually taking when they come in your office with new onset DM. But I think that's maybe the tip of the iceberg, because these days, I don't know if you have patients like mine, but they come in, they're on a million different things, and they're taking a lot of supplements. And there are a few of them which are really interesting, such as spirulina and blue-green algae and chlorella in particular, where there's a pretty good literature about it being quite immunostimulatory. And in fact, we've been working with this in the lab, and using flow cytometry, you can show that there's induction of, for instance, TNF alpha, a lot of TNF alpha in macrophages and monocytes and myeloid DCs. And so, it's really a concern. And so we decided to look at this in a more prospective way. And so we now have a template where we ask every single patient who walks in what herbs they're taking. And we did this for a control group of patients. We did this for cutaneous lupus, blistering disease, and then dermatomyositis. And what this is showing is that overall herbal supplement use was, threefold higher in the patients who had DM relative to all these other people, where there was no difference between the other groups. And the same thing was true with spirulina, and a lot of these patients take spirulina. And so, which again, the data, and in our lab, we found very similar stimulatory effects with spirulina, again, mostly through TOL4. And so I think it's really, it behooves us to try to get these patients to stop. However, I think once the disease is triggered, I'm not convinced that stopping the herb is necessarily going to make that big a difference. And so that gets discouraging for patients, and a lot of them, you'd be surprised, want to go right back on. And so it's really quite a struggle. So I want to go on then and talk a little bit about autoantibodies and phenotypes. And I think that's been an area that has been really of great interest. These are helpful in diagnosis and patient assessment. They can predict complications and prognosis, as well as potentially a therapeutic strategy. However, I do want to say that we're not there yet, and I'm going to show you some data that I do think that the problem is we don't have a good standardization of detection of antibodies, and I find myself taking some of the commercial antibodies and not knowing how to interpret them, and they keep changing, the platforms, and some of them are too sensitive and you don't know what it means, and they're inconsistent between platforms. And so we still send occasionally our serum to OMRF, the Oklahoma Medical Research Foundation, where there's a guy there that does immunoprecipitation, which is kind of the gold standard, and will actually characterize the autoantibodies. It takes forever. Because they basically do one antibody a week, and so 2 or 3 months later something appears that looks like a pretty complete list of autoantibodies. But I do find that there's not that always a correlation with what we're getting in the commercial labs. So in terms of the dermatospecific autoantibodies, so the MI2 we see a lot in our patients, and these patients tend to have skin and muscle involvement, but they tend to be pretty responsive to treatment. MDA5, if you have an MDA5 patient with ulcers, about half of them end up in the unit, and some of them end up with transplants, a lot of them die. It's really a problem, and it's important to identify those patients early and kind of throw the book at them in terms of therapy. And then TIF1 gamma is associated with cancer. However, I also call it the worry antibody. It turns out that about 20% of patients with dermato get cancer, and about 20% of people with TIF1 gamma have it associated with cancer. So that means there's a lot of people with that antibody who don't have cancer, and but if you look at patients who have cancer and TIF1 gamma, or have dermato and TIF1 gamma, they're much more likely to have cancer than those who don't have TIF1 gamma. So statistically, it's important, and it doesn't mean you don't work up everybody anyway for cancer. We need better guidelines for what to do and what makes a difference in terms of screening for cancer. But if somebody's TIF1 gamma, you're kind of obligated to look pretty hard for things. NXP2 is associated with, you can find that in juvenile DM. And what's interesting is you can see these antibodies in JDM, and it has almost like a different significance than what it does in adults. But NXP2 can be associated with calcinosis. It can also be associated with cancer, less frequently than with TIF1 gamma. And then anti-SAE. So I think it's good to be aware, and there are really a lot of myositis associated, and then also myositis-specific antibodies. It's good to be aware of them, and when you get a patient with them, you can think about what these phenotypes actually, or these antibodies may correlate with. And then there's the anti-synthetase syndrome, and part of that is having these antibodies, if you have one of these, such as JO1. And for whatever reason, JO1 seems to be the one that's on a lot of, is the only one that's often measured, but there really is quite a number of them, and I have lots of patients who have these other ones as well, or usually only one, but they may have something that's not JO1. And you could say, well, why check? Well, there is this syndrome, and it's defined by having at least one of these anti-synthetase antibodies, and then at least one of these ILD, inflammatory myositis, or inflammatory polyarthritis, and they can have fever, Raynaud's, or mechanic sense. And so the significance of this is just, there's a big debate now whether this is like completely separate from DM or part of DM and part of a spectrum, and it really depends on where you sit in terms of neurology, rheumatology, or dermis, or where this falls. And so we've been trying to look at patients who have anti-synthetase syndrome, but we can get their skin biopsies from DM-looking lesions, because it's pretty clear that people with anti-synthetase can have DM lesions that are not just mechanics hands, but the ones that you would typically see in a DM-type patient. And when you do this, what you can do is then do things like stain for MIX-A, which is a interferon upregulated protein, and we can look at interferon beta, and we wanted to compare dermato to patients who met the criteria for anti-synthetase syndrome. And what you can see here is that there really is not a big difference between the patients who have the anti-synthetase and DM in terms of the amount of interferon that they have relative to control, healthy control, and then also in terms of the amount of MIX-A. And so, there's still an ongoing debate about this, but this kind of data hopefully will push back a little bit to say this should be a spectrum disease. Again, why does it matter? Well, I could very easily now know that if we define this differently, then these people will not be included in studies. We will not know if our therapies are working, et cetera, et cetera. So then anti-MDA5 in Dave Fiorentina's cohort, that was about 13% of patients had DM skin lesions, and there was a higher incidence of lung disease, skin ulcers, palmar papules, mechanics hands, oral lesions, and alopecia. So I'm showing you some of the things that have been associated with the MDA5, but when you see these kind of ulcers, and sometimes it goes down to tendon, it can be really significant, but in particular lung pulmonary wise. And then anti-TIF1, if one looks at the skin, it tends to be more extensive. You can see these palmar hyperkeratotic papules. I'll show you some examples. Less calcinosis correlates with malignancy, and less ILD, Raynaud's, and arthritis, and mild myositis. And in one study, it seemed that the higher antibody levels on ELISA for TIF1 correlated with the presence of cancer, but that has not been duplicated, and so I think it remains to be seen. But this is the kind of psoriasiform lesions that can be seen, and you can see hyperkeratotic lesions. And you can see why maybe getting a biopsy is important, because there is a subset of patients who get called psoriasis. I've had patients who for 10 years were called psoriasis and got a psoriasis drug, and you do a biopsy and it shows interface dermatitis. So it's good to put in the differential. And then this is showing you the palmar papules. This is showing you the kind of red on white type changes that you can see. NXP2 is associated with cancer, and it was seen in about 11% of Dave Fiorentino's cohort. And NXP2 is a protein involved in regulation of p53-induced cell senescence. So if you're knocking that out, maybe it's increasing the oncogenesis. There is some association that's a little bit different, male gender. This peripheral edema is really interesting, and it does definitely happen. But again, the idea is that there are these phenotypes that seem to go along with these antibodies. And same with SAE. And so again, MI2 is seen in 20%. And again, this is your typical DM type patient. And it does tend to have some mild muscle, low lung and joint involvement, and it's steroid responsive, more of a monophasic disease. It's sort of one and done. You treat them and they get better. So I want to go over one study that we did based on antibodies, and we looked at patients who'd gotten a myositis panel at Penn. There were 378 of them, and we went through their charts and figured out who was probable or definite DM polymyositis or clinically amyopathic, and that was about 14% who had a positive MSA, or 14% of them had a positive MSA, and 21% had a myositis-associated antibody. So you can see that many of the patients didn't have antibodies who had it checked and in a commercial lab and had these diseases. And this is just highlighting the idea that our CADM patients, I find many times they don't have antibodies. It doesn't mean that they don't have dermato. So now when I order this test, I basically tell them, look, it's probably going to be negative. It only helps if it's positive. And you really want to warn the patients, because then they get so confused when they get their negative test back. So the use of commercial myositis antibodies has increased dramatically. I used to never do them because they were always negative, but now I get them, and then I get to interpret the results for the patients. And again, we have a lot of work to do in really improving the commercial testing that's available. So I want to end a little bit on therapeutics. So we do get PFTs with the diffusion capacity on all of our patients at baseline. And we don't get high-res CT necessarily unless there's something abnormal about the PFTs. But if they're abnormal, we'll get high-res CT, which allows one to look at the parenchyma. And we often will repeat PFTs yearly. If somebody's been stable for 10 years and never budged, I might actually not get it every year. We do the cancer screening based on age. We check a CPK aldolase. If those are normal and they don't have muscle symptoms, I go no further to work up muscle. If they have muscle symptoms or abnormal muscle enzymes, then we go on and do an EMG or a targeted MRI. Most patients prefer getting a targeted MRI. They don't like getting stuck with needles. And you need to have it done in a place where they know how to interpret the results with the muscle, which shows often edema. Another thing to think about is that in our amyopathic patients, we see a lot of microscopic colitis. A lot of patients have diarrhea, abdominal pain. And so Dave Pearson was a fellow with me a few years ago, and he did a study showing that, in fact, there's really an enrichment for clinically amyopathic DM over the historical prevalence. It's quite a bit of prevalence, and even compared to classic DM. And so this is very common. Many of our patients never get scoped or biopsied, but if they do, you'll occasionally get these patients back who have microscopic colitis and often need to be treated, and sometimes our treatments will help that. we spent a lot of time developing and validating the CDASI. You end up with an activity score and a damage score, and we've characterized mild, moderate, severe, and what's an important change, both from a physician standpoint and also from a patient quality of life perspective. And we can show that in people who get better in terms of a responder, in terms of their CDASI, their emotional score of quality of life improves. And if they don't get better, their quality of life doesn't get better. So sunscreens, again, very critical. Sun avoidance, sun, clothing, etc. You guys know a lot about that in San Diego, I'm sure. And then topicals are helpful, sometimes intralesionals, although I don't typically use it so much. And then topical microlimus or tacrolimus. And I do often use antimalarials such as hydroxychloroquine, but I warn patients that they may get a rash from it. And if they get exacerbation in the first few weeks after starting it, we stop. I mean, we see it in about 20% of patients. And you could say, why would you give a drug to somebody that's going to have a 20% chance of a reaction? And it's just because very often, if it does work, that they don't have to progress on to immunosuppressives long term. And then if that doesn't work, we sometimes will add quinacrine, which again, we are now able to get, but patients have to pay out of pocket. And then we'll switch to chloroquine sometimes if the hydroxychloroquine is not working. Now, this is just to say that quinacrine, we had looked back at some of our patients in our prospective database and found that about half the patients actually do improve with quinacrine when it's added to the hydroxychloroquine. So that what you can see here is that they went from a CDASI score of 23 down to 10, which is a significant improvement. The non-responders, nothing happened. And this correlated with an improvement in symptoms, but in particular also an improvement in the emotional component of quality of life, which is also very important, something that was not seen in the patients who were not responders. And so we do think quinacrine is helpful if you can get it. So second-line therapies are immunosuppressives, and we tend to use either methotrexate or mycophenolate. Sometimes if we're having problems, we'll go to tacrolimus. I don't think azathioprine works as well in skin for dermato. And I find I use a lot of mycophenolate. I think it probably works a little better than methotrexate. And with fatty livers and everything else in drinkers, I find it easier to use mycophenolate, although it's probably more immunosuppressing. We use steroids more as a bridge. I try not to use it long term. And then IVIG can be helpful, again, as a bridge, but for very refractory patients, they may be on it long term with monthly infusions. And TOFA may help, but there's one small 10-person study that suggested that it was effective for skin. This is data that we've recently is in press right now. And I think the point of showing you this is this is the MMF on the left patients, and this is the methotrexate on the right. This is looking at the skin activity score, and what it's meant to show you is that there are more blue downward trending patients here than we're seeing over here. And this is more red, this is more blue. So MMF seemed to work better, but in particular, if MMF is going to work or methotrexate, you tend to see improvement early on, which is good. If you have a patient who's been on it for 3 or 4 months and they're not getting better, it's probably a waste of time and they just stay not getting better. But the ones who are getting better continue to get better over a long period of time. And that's problematic for trial design because if the patients are on therapy, that means our placebo group is going to be getting better as well. And so you better have a really good therapy. There was a recent study that was presented at the ACR last year and showing that IVIG anoctagram preparation was effective. And this is looking at the rate of patients without a response. And what you can see here is that the placebo did worse than the patients who got IVIG. And I think we all know that in many patients, not everybody, IVIG can work. But this was a really good study that really proved it. There's some experimental therapies. Rituximab failed in terms of the trials that were done, and there was a large trial, one of the first trials for DM. And unfortunate because it probably does help refractory muscle and it's used for that indication. I think it's less beneficial for skin, and so I don't tend to reach for it in a refractory patient, especially in the COVID era. But I think that it's something to consider for a very refractory muscle patient. And anti-interferon beta is very interesting. If there's an ongoing trial, it clearly works, and it's going to be very exciting to have some therapies in the future that help. As you probably know, anifrolumab, which is an anti-FNR receptor antibody, which blocks all type 1 interferons, was recently approved probably 2 weeks ago for systemic lupus. And it has not been studied in DM, but there's no reason to think that that may not also be effective, but it's not approved for DM. So in terms of other new therapies, we've been very involved in the study with lenabasum, which is a CB2 agonist, and it has a lot of immunomodulatory properties. We designed and did the phase 2 trial, which was successful for skin. And CB2 is expressed on a number of inflammatory cells. And also this drug suppresses secretion of a number of pro-inflammatory cytokines, including IL-31, that are important in DM. This just shows in vitro studies where we took PBMCs from patients and gave them different concentrations of linabasum. And you can appreciate, which is a CB2 agonist, and this is interferon beta, which goes down. We've done this with alpha and TNF as well. This was the phase 2 trial, a very short trial where the patients only got full dose drug for 2 months. This was the first part of the trial. They were on low dose and then they went to higher dose, and you can see that the curves separated, the orange being placebo, and this was the treated group, with a statistically significant result with only 22 patients at the end of a year of the 4-month trial. And so this was exciting to us, and this is the kind of improvement that we saw before on the left and after on the right. And this was looking at some of the other outcomes, such as the patient activity VAS. Again, the blue treated group did better than the orange. Skin death symptoms similarly, and then PROMIS 29 pain. We did a lot of biomarker work, and we've done a lot of work to try to understand how CB2 is working in our lab. But just to summarize from the perspective of the phase 2 trial, we were able to show that CD4 cells went down in those treated with linabasum relative to the placebo. So this is at week 0 and week 12. You can see many fewer CD4 positive cells, and that finding, we did not see that in the placebo group. We then went on to do a very long-term extension showing the safety of the drug and continued efficacy in terms of the skin, in terms of the symptoms and activity. So basically, the side effects were quite minimal, and the patients were quite appreciative that there was a drug that seemed to be helping, and we went into long-term extension with this open label at the end of the trial. And we saw, again, all these improvements and the biomarkers improving. So that led to a phase 3 trial, which just got read out in late June. And the primary endpoint was the TIS, which is a score that was developed very much weighted to muscle. But in this study, we were able to enroll both amyopathics and muscle patients. And the TIS didn't work for the patients who weren't weak because it was weighted for muscle. And so you had to have, they used MMT, which is a huge weight. They had to be at a pretty low point to be able to capture improvement using that score. So that's something that the FDA drove, and we've had a lot of problems with the FDA understanding the skin and some of our autoimmune skin diseases. They want to use measures that just won't work, like global assessments, and so it's a concern. So the CDASI was a secondary endpoint. As you can see, it worked quite well in the patients who had skin activity. So on that not so happy note, it's not so clear. I mean, they may have to go on and do another phase 3, and hopefully we can improve on the outcome measures that can be used, going through the rheum division, because the skin division is really not allowing these trials to go forward. And then anti-interferon beta, the phase 2 is finishing, and they're beginning to favor more the muscle patients as well, which is, again, this drug works for our patients. We should be studying it in our patients. There is an ongoing sub-Q IVIG study for patients who don't want to be hooked up to an IV pole, for hours at a time, multiple days per month. And there are other ongoing trials. Unfortunately, the beta-sept trial is coming out, and it's the top level results. It's not clear yet that that's going to be a positive trial. So in summary, I think we do have better classifications that include amyopathic dermato. We have, I think, continuing to advance our understanding of pathophysiology. I would ask you to tell your patients to avoid immunostimulatory herbs. We have a handout now that we give to every single patient, and they are supposed to check whatever they decide they need to take. And we have disease severity tools that are working for skin, and several potential therapies in development. And I think with that, I will stop and be happy to entertain any questions.
Thank you, Vicki. That was wonderful. I really appreciated how you brought together the clinical and the research and translational work you've done all together. We already have some questions. So Dr. Orm was wondering, what do you think about HelioCare polypodium leukotomos for DM patients?
Yeah, I mean, it's a very interesting drug. It's been used for polymorphous light eruption. I've used it in some of my photosensitive patients. If you don't know, it's basically available, through Amazon, and you can buy it. And I don't think there's good standardization of the different preparations. That's one concern, and we don't have trials. I think there was one case report in cutis in one patient with lupus where it seemed to help. I must say I've had a few patients using it off label, so to speak, that haven't really seemed to think it worked. So I think the jury's out, and I don't know what to say about that.
Thank you. And Dr. Oldermer, one of our chief residents, asked, do these autoantibodies, I'm assuming the myositis specific autoantibodies, play a role in triggering disease, or are they just bystanders?
Great question. I don't think we know. We have many patients who don't have antibodies who get disease, so clearly you don't need to have them. I'm beginning to think from some of the work we're doing that there's more than one pathway that can be activated leading to DM, and there probably are some patients where these antibodies are pathogenic and triggering pathways that are, part of the process. But we really don't have chapter and verse yet to be able to say much about that. Yeah, some people think it's more of an epiphenomenon and true unrelated, but I think it will not surprise me that it's going to turn out at some point to be shown to be more pathogenic.
And piggybacking on that question, so do you ever get referrals for patients who really don't have very many clinical features suggestive or pathognomonic features of DM, but they come in with positive myositis specific antibodies and they're referred to you? What do you what do you do with those patients? How do you manage them, and how do you educate their primary dermatologists on what to do next?
Yeah, I mean, I just saw one today. I mean, I see them all the time. I call them the dermatomyositis, right? I mean, I think I'm very hesitant to label somebody if, in fact, that was the case today. I mean, somebody who had a low TIF1 gamma, and I'm going to check the OMRF antibodies because he said one test that was negative and one that was low positive. And I kind of put it in the context of the patient, and they don't really kind of fit, and they don't have enough to push me towards thinking, they don't have a biopsy showing interface and at least some characteristic findings. I'm not going to want to label them. I want to kind of follow them and see what happens.
Great. And Rich Gallo was asking, have you started suggesting COVID booster for all your autoimmune patients?
Well, that's an interesting question. I'm probably the wrong person to ask that to because, and I don't know, I think that we've had this in our Rheum Derm Society. I think we have a group of patients that there's a subset of these patients when they get their vaccine, their first vaccine, their second vaccine, there's something that alters in their immune system. I've seen some very scary things in these autoimmune patients that I just can't chalk up to just, random things. And with rapid acceleration of their disease or rapidly changing to a different disease, usually 2 weeks after they get their second vaccine. So I have patients who've gone from a diagnosis of DM to 2 weeks after the second vaccine, they now have mucosal pemphigoid, and they're working in an institution where they're supposed to get a booster, and I don't know what to tell them. And they ask me, am I supposed to get a booster? And I'm like, boy, do we not have data. So we are actually systematically trying to collect data on everybody that we see and trying to figure out, it's a very low percentage of people that have problems. So I advise everybody to get vaccines, and I really feel strongly about that in this scenario. But if they've had a real flare of their disease, which I see pretty regularly in DM, I don't know what to tell them, and very often they won't get it. So it's not up to me. But I think everybody else, right now, if they've gotten Rituxan, where people basically don't make antibodies, or if they're on Celsep or methotrexate or high-dose steroids, I mean, the advice is that they should get a booster if they're, and I think that's right, and I do ask them to do that. I think it's not so clear if somebody's on hydroxychloroquine or has an autoimmune disease but not on a lot of therapy. I don't think we're there yet. I mean, I think within a month we're all going to be getting boosters. So, I think it's a little, so it depends on what their background therapy is.
Yep, Vicki, thanks for that. Hopefully, actually, I want to let everybody on the Zoom hear this because it's very new information. It's not published yet, but a paper will be coming out September 1st in New England Journal based on some analysis of our cohort here. It looks like the vaccine's effectiveness in the young, healthy healthcare population last month to prevent infection, not serious disease, was only 44%.
Hmm.
So the combination of increased viral exposure, perhaps coincident with back to school, as well as time past immunization, and the vaccine that was studied was both the RNA vaccines, Moderna, Pfizer. It's way worse than it used to be.
Yep.
So, you're right in that it's like it actually also the government, the Biden administration may be switching the 8 month down to 6 months for post-vaccine. So it's likely everyone is going to be in the healthcare industry, at least, is going to be offered a vaccine very, very soon. And there may be such a surge on vaccine demand in the next few weeks that there may be actually some limitation in accessibility again.
Yeah.
So I'm particularly concerned, like in this week or two window, with even our mildly increased susceptible patients, whether or not we should be starting because they can, it's easy for them to go into the local drugstore now and say, I'm immunocompromised, I need a vaccine booster, and they'll get it.
Yeah. And
without the data on increased risks in these small cohort patients like DM and so forth, what do you do?
Well, we need more data, and that's what we're trying to generate right now. But I think, I think you're right. And the patients who are on immunosuppressives, they're reaching out. My inbox is blowing up all the time with them reaching out, and I always tell them to go get the vaccine if they're on Cellcept, if they're on methotrexate. They need to go now.
Right.
Yeah.
Yeah, that's what we were able to do easily at the VA. It's a little harder for us to do it at UCSD, but I think our individual docs could use their discretion with patients, and we just don't have all the data.
Oh, boy, do we not have it. But I can tell you, there's some scary anecdotal things that I could tell you, and it's not just one or two patients that and really has been life altering, the reactions that they've had 2 weeks after their second vaccine. So, again, you don't want to make it. It's really important to have this in a real population based kind of careful approach.
Thank you.
All right. Other questions?
Questions, yes. So in a patient with mild suspected disease, not biopsy confirmed, with negative myositis antibodies, how often do you follow these patients?
Yeah, that's a great question. The spectrum of disease activity is quite variable, and if they don't need anything more than topicals, I might tell them, if you get short of breath, if you get other symptoms, you need to come back, and I might not see them very often. I have a lot of patients I see once a year. I just can't fit them in my schedule, but they don't need to come back more often. If they, the one I saw today who may or may not have DM, he's got something hematologic and mixed cryos, and and he gets anemic and needs transfusions. Well, that one I'm going to be seeing a lot more often, and he probably has a malignancy. So it really just depends on the patient. And the lung patients, some of them, I have a high incidence of ILD in my practice, probably 40%. And so I do a lot of co-management with pulmonary and rheumatology, and those patients get seen much more frequently.
And following that question, so if a patient, you're highly suspicious for DM, but they have no complaints of pulmonary symptoms, are you still getting the PFTs?
Yeah, most of the patients who have ILD don't even know it. They're frequently asymptomatic. So I get PFTs at baseline. If they're low, I'm going to follow them more often. If not, it'll be a year. But I have people who've had it for 5 years and their skin's been stable, and all of a sudden they start developing ILD. So, and the other thing is that the pulmonary clinics are now much more aware in their idiopathic ILD type clinics that they need to be doing autoantibodies, because those are the patients who may have anti-synthetase antibodies, and they are now screening and finding these patients, and then they'll send them to me to see if I think there's anything on their skin. And so, they're alerted, but, I think every situation, I think in derm, we need to screen our patients initially, and then at least at the beginning every year.
Thank you. And then a question, any anecdotal evidence on the use of over-the-counter cannabinoids, which might be more accessible for patients now?
Yeah, I certainly have lots of patients who use them. I can't say that they seem to want to come into my trials, so I guess it's not working for them very well. I mean, I don't know that we have any evidence that I could say one way or the other, but uh, I'm not convinced that it's doing too much. But I don't have a huge N either.
And I have another question. Do you use a standard screening tool for colitis? I actually recently had a patient who was on, she's on Plaquenil, tofacitinib, IVIG, mycophenolic acid, and then ran out of her tofacitinib and started to develop GI upset, and then had a scope and diagnosis confirmed ulcerative colitis. So is there a
Ulcerative.
standard? Mhm. Is there anything, do you screen all your patients when they first come in, or it just based on their complaints that may come up?
Yeah, I just do it based on symptoms, and I honestly don't see that much ulcerative colitis in DM. I mean, I think that's just a co-association of two different autoimmune type problems. But whereas I think the microscopic colitis, it's quite prevalent, and so usually what happens is they'll tell me that they're having diarrhea 5 times a day, and it's been going on for years, and and then they'll get worked up, and then they have a biopsy that shows microscopic colitis.
Okay. Well, thank you, Vicky. Thank you so much. We really enjoyed your talk. Thanks for making the time.
Absolutely. Thanks for the invitation. Great questions. Bye bye.
Have a good rest of your day. Thank you, everyone.